Hello and welcome. I'm Saad Dino, pharmacist and co-owner of Acton Pharmacy and West Concord Pharmacy. I would like to welcome everyone back to our show, A Healthier You. Our goal is to discuss relevant health topics and to provide information that will guide you to a healthier life. Today, we will be discussing surgical procedures with Dr. Eric Mahoney, General Surgeon at Walden Surgical Associates, based at Emerson Hospital. Dr. Mahoney trained at Brown University, Rhode Island Hospital, and is board certified in general surgery and surgical critical care. Dr. Mahoney, welcome.
Thank you very much. I'm honored to be here.
Thank you so much. Thank you for joining us today. We're excited to have you. Can you please tell us a little more about your practice and how you became a surgeon, if you may?
How I became a surgeon, as you stated, I trained at Brown University. It was an incredible opportunity.
Okay.
And then after my fellowship in critical care, I was a surgeon downtown doing trauma and critical care. But after several years, I wanted to come to the community and practice community general surgery. So my practice now is multifaceted. I do mostly bread and butter general surgery, gallbladders, hernias, things we'll be discussing today.
Sure.
But I'm also board certified in intensive care medicine, so I do specialize in the critically patients who are in the intensive care unit. And that's been an exciting time at Emerson recently.
So you've seen many types of surgery.
Many types of surgery, right.
Okay. Well, thank you for sharing that with us. So I've been told that one thing that you do to help calm your patients' nerves is to literally illustrate the procedure. Why does that tend to calm patients down?
Well, first,
or nerves?
And this is my picture of Saad. So, of course, he's smiling. All my patients are happy here.
Okay.
And so, first, it's a comical picture to caricature, and often because we're discussing very serious topics, it helps to alleviate some of the tensions, and they will feel more comfortable.
Okay.
Also, it's an opportunity to slowly, just deliberately draw out what we'd be doing, what the problem is, and an opportunity for them to ask any questions as we go along. Patients often enjoy it. It serves as a reminder. They take it home so that they can then discuss it with their family members to help them understand the procedure.
So one of your areas of specialty is hernia.
Correct.
So how do how do we surgically treat hernias? And can you illustrate how if I was a patient having hernia, how you would start that discussion?
Sure. I can illustrate them here. So hernias come in various locations. They can happen in many areas of the abdomen. Most commonly, they're in the groin, and what a hernia is a hole in the muscle through which something will come through, either a piece of fatty tissue or a piece of intestine.
Okay.
Majority are not due to injury, although the classic description is somebody lifted something heavy, they suddenly felt a tearing, and then developed a bulge and a pain in the area. That is actually the least common. Most commonly, people just happen to notice some bulge or area of discomfort, and that's what brings them to see me.
Okay. Is there familial or genetic?
There's no real genetic. It is common in men, more commonly than women, hernias. Okay. However, any patient that's had an abdominal operation is at risk of developing an incisional hernia. And so hernias can develop at incisions, in the groin. They can happen at various areas of the abdomen.
Is the treatment different, or is it's all?
Treatment is different based on location. Can be done either through an open approach, a laparoscopic approach, and most times we need to use a mesh, which is a synthetic material, to help buttress and support the repair.
Can you describe the different procedures that you just a little bit elaborate on
Sure.
the two procedures?
Sure. May I use
Please,
this board here for a
please.
second? This is a picture of a gallbladder, which I believe we'll discuss later, but a hernia, most commonly, is literally a hole in the muscle through which patients develop a bulge. Okay. And that can create a lot of discomfort, and in rare circumstances can lead to intestine becoming entrapped in the area. So the way we would fix it is either make an incision right over the area and cover it with a mesh, and then close that area. Or we can do it laparoscopically, whereas we make a small incision by their belly button, I insert a camera, and then we'll insert the mesh internally. And there are different reasons for different approaches.
Okay, and why would you choose one over the other?
If a patient has a primary hernia, has never had an operation before, and it's only on one side, you just make a small incision over where the defect is and you put the mesh in there.
Okay.
However, if patients have them on both sides or this is a recurrence, then a laparoscopic is a favored approach.
And Dr. Mahoney, with hernias, I know from a family that sometimes they reoccur. Mm-hmm. And what would be the cause of that? If there's such a known facts?
They do reoccur with different incidences depending on location. For a groin hernia like this with mesh, the chance of recurrence is usually 1%, laparoscopically slightly higher, maybe 4%, just a more difficult operation. Versus if someone has a hernia at an incision, well then recurrence rates can be as high as 20%. It's just a more difficult area. Because you would like strength at your repair, but you still need flexibility, and so it's often a trade-off. And so patients can have recurrences just based on the nature of their hernia, based on location, based on technique of repair, and of the size of the hernia.
So let's say if I got a hernia, am I apt to have one again, or is that the chances are slim in that fact?
If you've had a hernia in the groin like this, the chances of it having again is rare. Recurrence rate would be less than 1% with just one-sided. If you have a hernia at a previous incision, for example, if you had a previous abdominal operation and you have a hernia there, the chance of having a recurrence there can be anywhere from 8% if it's a small defect to upwards of 25% if it's a large defect.
It's 1 in 4. Okay. And you specialize in abdominal wall reconstruction.
Correct.
When would a patient need this surgery, and how would you approach it?
Abdominal wall reconstruction is a technique in which you are able to mobilize the muscles of the abdomen and bring them together to try to decrease the recurrence of a hernia. In patients who need that type of operation are people who have a very large hernia, or patients who have multiple hernias, or someone who's had recurrence from previous attempted repairs. Because in those situations, you need to bring in healthy tissue to try to improve outcome.
And that's what...
And that would be the abdominal reconstruction.
I think you alluded to it earlier. You know, surgeries could be tough, and you know, there's different types of surgeries. And obviously emotionally, anxiety and all that stuff comes into effect when it comes to the patient. As a surgeon, what do you do beyond illustrating the procedure to help ease the anxiety of the patient?
Most of it is education.
Okay.
Patients come in with a lot of questions, and so just taking the time to sit down and talk with them. Yes, we draw the silly pictures, we have some laughs, but also providing them education on what the problem is, different techniques, and just any concerns that they may have, how it's going to impact their occupation, their family life, and just the timing of it. Often, just the time spending with the patient often alleviates their anxiety.
So you know, you've heard that surgeries sometimes fail, or the recovery is not as well as anticipated. What do you attribute that to, if I may ask? I'm not sure if you'll know. You know, is there studies that have been done, or is it patient compliance? Not.
Actually, one thing that's clearly been shown for hernia operations to fail is smoking. I will tell patients that if you have a hernia and it's not an emergency repairing them, your chance of having some type of negative event, either a small infection or a complete failure, can be upwards of 30 to 37% from smoking. So you absolutely need to stop smoking before any type of elective operation.
What's the correlation? I mean, besides we know smoking is bad.
There's, as we know, there's about 400 chemicals in the smoke itself. Yes, there's a chemical that will give you cancer, but there's something else that's been shown to impair wound healing. And that lasts for 3 weeks from the last cigarette. And so I will tell patients, if you're still smoking up in the time of the operation, you have approximately 30 to 37% chance of a failure. Okay. One example I give them is, would you ever buy a car if you knew that in a year you have a 30% chance that it's going to fail? You wouldn't buy that car. So don't buy that operation. Things that you can do to improve your outcomes, and stop smoking is one of them. Often I ask patients to increase their exercise before the operation. If you're training for any type of sporting event, you would increase your activities before, and ask them to do the same thing, because this is a stress on the body, and the body needs to overcome that, and so you train for it. And it's clearly been shown that patients do better if they increase their activities before the operation. It doesn't have to be strenuous, but increase their cardiovascular activities.
Now, specifically on hernia, are there treatments besides surgery that you would recommend, or ultimately surgery is the way to treat hernia?
Well, reasons for operating for hernia would be, one, incarceration. If a piece of intestine or something became stuck, that's an absolute emergency. Go straight to the closest emergency room and tell them that you have an incarceration. Okay. However, indications for operations are more commonly functional impairment. It's just uncomfortable. Right. Unfortunately, none of the products available, trusses or things like that, actually decrease the risk of incarceration. Okay. They may provide some support, but they don't decrease your risk. And so we'll talk to the patients about that.
I mean, you know, as a pharmacy, obviously we've sold some hernia belts and hernia trusses and abdominal, belts and stuff like that. What cost should our customers or our patients or our audience have when it comes to those things?
For those, I tell them, yes, you may provide some support from your abdominal binders for midline, and that can provide a lot of symptomatic relief. You just have to know that the patients are still at risk of that incarceration because eventually you have to take that belt off.
Okay.
And so they need to be educated on what signs to look for where it may become more serious.
And do you mind elaborating on the incarceration? What symptoms may occur, what the patients are, should be looking out for?
I would say any patient who's symptomatic should be seen by their physician or a surgeon just to discuss it. What an incarceration is a hernia with that hole, a piece of intestine comes through that hole and becomes trapped. And that would show itself as a firm mass that becomes increasingly uncomfortable. If you wait long enough, the area starts to turn red. It's an absolute surgical emergency. For midline incisional hernias, the risk of that is fairly low. It's only about 4 to 8%. However, if it happens, it's a clear emergency. And so you just need to be educated for the signs to look for.
And when that preclusion happens in the intestine, that could also cause blockage all the way around.
What it can do is it can block the bowel itself, so they develop a bowel obstruction. It can block the blood flow to that portion of intestine, and that segment can die and then rupture, and then the patients can become critically ill.
Well, thank you for sharing that. Do you want to do the gallbladder
Sure,
illustration? Do you
sure,
mind? This
sure.
will be a good time.
This is our picture of our gallbladder, and this side here is very happy. So when you eat, food goes down your esophagus, goes into your stomach, and then it goes into your intestines. Up here is your liver, and as you know, amongst the 400 things the liver does, one thing it does is it makes bile. And the bile is there to help you digest greasy, fatty foods. And so the bile goes from your liver, and it gets stored here in your gallbladder. And the gallbladder's job is to store and concentrate the bile between meals. When food goes into your stomach, particularly greasy, fatty foods, it triggers the gallbladder to contract, and it will squirt that bile into your intestines and help you digest that greasy, fatty foods.
Okay.
Unfortunately, some people can actually form gallstones. So the bile is supposed to be this watery green liquid, but over time it can turn into this sludge, like a molasses or a used motor oil consistency, and then to almost a slushy material, and then will eventually form stones. And the stones will stay in the gallbladder. In most people who have stones, they're not symptomatic. However, as the gallbladder contracts, it can squeeze against those stones, and it can become very uncomfortable. Or those stones can actually move into this tube here called the duct, and they can actually become stuck there, and then it's become increasingly symptomatic.
And symptoms of gallbladders, I know one of them is pain, obviously,
Right.
but what other symptoms could there be?
The classic description of gallbladder attacks is right upper quadrant pain that radiates to the back and the right shoulder, and it can be very severe. The most common description, though, is pain right here in the middle of the abdomen, usually 15 to 60 minutes after eating a greasy meal, can last upwards of an hour or so while the gallbladder is being stimulated to contract. And it's usually produced reliably after eating greasy foods.
And these gallstones, do they ever end up in this area of the stomach?
They can become trapped here and create an emergency. If they do pass, their majority will pass on their own. It will be very uncomfortable while they pass, but they can pass, and then they'll just pass through the intestines. Rarely will they actually cause any problems with their intestines.
So what does the surgery involve when it comes to gallbladder?
Most of the time, we can do it the same day through a very small incision. We usually can do it laparoscopically. Unfortunately, with gallstones, once you form them, there's no medication I can give you to dissolve the stones. We're unable to treat them like stones in other areas with lithotripsy or ultrasound. So the only thing that reliably works is just to take out the entire gallbladder. And the way that is done most commonly is with a laparoscope. So at your belly button, I make a small incision, and this time I put my camera up this way. And then I make 3 other small incisions for my instruments, and then as the camera is projecting the image up on the screen, we can take it out laparoscopically. And the patients are left with 4 small incisions, and they generally go home within 3 hours after the procedure.
Wow. And obviously a human being can live without a gallbladder.
Actually, majority tolerate it very well. Instead of the bile being stored here, the bile just constantly becomes secreted into your intestines. 25% of patients do develop some intestinal discomfort, a little bit of diarrhea for about 2 weeks after the operation. It's not severe, it's just more of a discomfort, but majority of the time that resolves on its own. 75% of people have no effect. They tolerate it well and have no intestinal problems after the operation, just a little incisional pain.
So the gallbladder is out.
Completely.
Does someone have to change their diet?
We usually ask people to have a low-fat diet before the operation because the fat will stimulate the gallbladder.
Okay.
After the operation, the patients can really eat whatever they want to eat. I do recommend a low-fat diet because that's what we're all supposed to be eating anyway. But they can go back to eating their regular diet just as they were before.
And the system will still function as
Majority of the
opposed
time, they tolerate it just fine. Yep.
Okay. And the medication they have to take after
Usually just some
gallbladder?
pain medications at your incisions.
Okay. Interesting. Thank you. Great illustration. So, I think you alluded to this earlier, Dr. Mahoney. What patients can do generally to speed recovery from surgery?
It's usually things they can do beforehand just in order to get them better prepared for the recovery. Increasing exercise, stop smoking if they smoke, healthier eating, low-fat diets, things like that if you're going for a gallbladder operation.
Okay.
It's usually things beforehand just to get them ready for the stress of the operation.
And you also discussed this a few minutes ago about pain meds. What kind of pain meds would I'm assuming it's each individual is going to be different, tolerant to pain and tolerant to the surgery itself. What kind of medication are we talking about when it comes to surgery?
After the operation, most patients do require some narcotics. We try to minimize them as much as we can. And we do also use things like ibuprofen and Motrin to supplement that in patients as long as they have no contraindications to that type of medication.
So, as a physician, there's tons of abuse with narcotics. So, we're trying to lean more towards medication that don't cause narcotics, and I'm assuming that you guys try to do your best to
Absolutely.
lean towards those kind of class drugs.
Correct. Whether inpatient or outpatient, we try to minimize the use of narcotics. Again, it is part of the recovery. Many patients will need it, but we try to minimize that. We do try to supplement the narcotics with ibuprofen, Motrin, and that class, or away from the traditional narcotics and use some of the other synthetics, have less risk of addiction. Addiction is rare, but you still need to be aware of it.
So Dr. Mahoney, how do you get patients? I mean, how do they find Dr. Mahoney?
Okay. I am at Emerson Hospital. My office is right on the main campus. I'm in the Cummings building.
Okay.
I'm happy to come in and have them talk to me, and we can discuss any procedure they would do.
And so they're getting referrals from internist or from ER, or where are they coming from? Mostly?
Many patients will be referred from their primary care physicians,
Okay.
As well as through the emergency room, or if they're in for another condition, they may see me while inpatient.
Dr. Mahoney, we discussed first hernia surgery, then we discussed gallbladder surgery. Any other types of surgeries you would like our audience to be aware of? I know there's a lot of issues with colon, Crohn's, or diverticulitis. If you could elaborate on that.
Particularly
that'd be great.
diverticulitis, diverticulosis. Having a diverticulum, which is an outpouching of the colon, is very common. Many people will be told that they have that. Although many people are not symptomatic from it, people can have inflammation of the colon. If I could, I'd just like to draw
Please.
something. I want to fix your drawing slightly.
That's good. No, that's,
Gallbladder's removed.
yep, that's gone.
So now you have your small intestine,
Okay.
then that goes into your colon. So this is your stomach, to your
Yep.
small intestine, and to your large intestine, also called the colon.
Okay.
What can happen is people can form these outpouchings on their colon that we call diverticulum.
Okay.
The example we give is the bicycle tires from many, many years ago. Before the tire would actually pop, it would balloon out, and you would see a little bubble of air before it popped.
Yes, sir.
So many of us remember those tires.
Yes.
So our intestines can actually form something very similar to that. You can form these little outpouchings along the entirety of the colon, but it's most common in this location of the colon. And again, while they're most commonly not symptomatic, just an incidental finding during a colonoscopy or a CAT scan, these can become inflamed after something gets stuck inside of them. That can lead to inflammation and in some cases actually perforation.
And are there certain people that are more vulnerable to this than others, or how does...
The diverticulum, the number will increase as we all age. They're
Okay.
thought to be due to a low fiber diet throughout a lifetime. And so the U.S. diet, the Western diet, is insufficient in fiber.
Okay.
getting better.
Fair enough.
But the thought is a lifetime of insufficient fiber will increase your incidence of having these diverticulum. There are some familial associations with it, but most commonly it's thought to be due to low fiber. And so you can try to limit the symptoms of these by eating a high fiber diet.
And you said the chances of them happening here are very high?
Most commonly in the United States and the West, they're most commonly here in this portion of the colon.
So you do see them?
You do, but
Okay.
they're much less common.
And surgery, what does that involve when it comes to this?
And so that's actually had quite an advance over the past 5 to 10 years on what we would need to do for this type of disease.
Okay.
If it's mild with just some inflammation of the colon and it's your first attack, antibiotics are often sufficient, and that's all the patient would need, and then a follow-up colonoscopy to make sure that there's not something more sinister going on, even though it's rare for something like that happening. If they develop an abscess, in the past we used to need to operate on those patients. Now, if they develop any type of collection here, we can, under CAT scan guidance, we can have that collection drained and avoid any operation until a patient's in a better situation.
Wow, that's a great investment.
It's a huge advancement.
And doctor, do you deal with colon cancer, or you do?
We do.
So can you elaborate on, on that just a little bit, and also the importance of colonoscopy?
Colonoscopy.
Please.
Colonoscopy, I cannot stress enough, as you know, how important colonoscopy has been for patients identifying cancers or precancerous lesions much earlier on. And in those cases, you can resect them when they're very early, limit their resection, better recovery, and that will improve patient outcome.
And I remember, from we used to dispense these gallons to patients to do before colonoscopy, and that's kind of gone away a little
Correct.
bit. So there's an outlet for people to get their colonoscopies done. What are the recommendations now for colonoscopy?
Colonoscopy is recommended for anybody over the age of 50, unless you have a family history, and then we recommend it sooner than that. And your gastroenterologist will tell you how frequently after your first colonoscopy you should get your next one, and that will be based on the findings at colonoscopy as well as your own personal risks. With the colon operations, those have also had quite a bit of advancement.
Okay.
Many times they need to be done through a midline incision, but more and more frequently we're able to do it laparoscopically. And that's one thing we do at Emerson Hospital. So you can have a laparoscopic operation here.
Okay.
Or sometimes we do need to do the traditional open incision, but people are concerned that they may require an ostomy. And I just want to know that that is not very common. Less than 10% of the time, even in emergent situations, we
Really?
need to do that, and that's a big advancement.
That's come a long way.
That used to be the standard.
Yep.
Now that can often be avoided. So the concerns people had about the operation, I hope to alleviate them. That in an elective, if you can plan this, you can often avoid that type of that need for the ostomy.
Excellent. Wow. Medicine has come a long way.
That's a long way.
A long way. So we discussed colonoscopy, how important it is. We discussed, so just to summarize our talk a little bit, we discussed, started with the hernia, we started with gallbladder,
Correct.
and we went into the lower intestines, specifically the colon. And anything else you'd like to finalize or summarize, Dr. Mahoney, before we finish?
I do want that if patients are having symptoms, of course, any type of pain, please contact your primary care physician,
Okay.
because he or she can go through that, maybe something very benign, or it may be something that requires some type of operative intervention. I would say talk to your doctor. Be more than happy to help. Talk to your pharmacist.
Thank you.
Because I think actually that is an underused resource that would help patients a lot and alleviate a lot of their concerns, because often patients are going on multiple medications and they would need a lot of education for that. So there's a lot of resources out there that you can immediately tap into.
Dr. Mahoney, thank you so much for being here. Your illustrations were incredible. We appreciate it. As mentioned, surgery can be stressful and scary for those undergoing it. However, with knowledge and support, those apprehensions and anxiety can be alleviated. Thank you again, Dr. Mahoney, for taking the time out of your busy schedule to speak with us today. And thank you all for tuning in to A Healthier You. For health-related topics and information, you can find us on Facebook at facebook.com/Acton Pharmacy. I'm Saad Dino, co-owner of Acton Pharmacy and West Concord Pharmacy, and I look forward to seeing you around town. Be well.